My screen is visible to everyone, right?
Yes, ma'am.
Okay. I'm audible as well, right?
Yes, ma'am.
1 second then. Okay. We will start with oncological emergencies part 1 today I'm taking. So in part 1, we will be covering two topics, febrile neutropenia and hypercalcemia of malignancy, two very important topics. Mehul, in between, if my voice is down or any issues, please let me know.
Sure, ma'am.
Okay. And so these two are the topics which we will be covering today, of which febrile neutropenia is very common and hypercalcemia of malignancy is also not a rare finding. Okay. So first topic is febrile neutropenia. So I would say febrile neutropenia, first I would say an umbrella definition. It is defined as a documented fever of more than 38 degrees Celsius, that is 100.4 degree Fahrenheit or higher, and an absolute neutrophil count of less than 500. That's an umbrella definition, a broad definition. And we have different specific criteria for the fever and the absolute neutrophil count or the neutropenia. Okay, and whatever today I am describing in this session, all the points have been taken from ASCO and IDSA guidelines of 2018, and I will share this later on in the group as well. Okay, all these guidelines. So the febrile neutropenia, in that fever component is defined as a single oral temperature of 38.3 degrees Celsius, that is 101 Fahrenheit or higher, or a temperature of 38 degrees Celsius or 100.4 or higher, sustaining over a 1 hour period. That is defined as fever, typically seen in 5 to 10 days after the last chemo. And neutropenia is defined as, neutropenia we will come to that again, ANC less than 500 or expected to fall in the next 48 hours. Mehul, how will I minimize this one? This small
Ma'am.
box. How will I minimize this small box? This one.
You can move it around, ma'am. It won't actually minimize as such.
Okay. Okay. So, patients who have received chemotherapy in the last 6 weeks, those are our patients with a fever as defined as more than or equal to 38.3 degree Celsius, that is 101 Fahrenheit, a single reading, or a temperature more than or equal to 38 degrees Celsius sustained over 1 hour, with a neutropenia which is defined as absolute neutrophil count less than 500, or an ANC which is expected to decrease to less than 500 in the next 48 hours. For example, suppose the absolute neutrophil count is like 700 or 600, but we know the patient is having persistent fever and all the symptoms, and it will definitely fall in the next 24 or 48 hours. So that is also included in neutropenia. So this is the definition of febrile neutropenia as per the ASCO guideline. Okay. So ASCO, that is American Society of Clinical Oncology, has defined neutropenia as ANC less than 1000 per microliter, severe neutropenia is less than 500, and profound neutropenia is ANC less than 100. So we say ANC. How do we calculate ANC? ANC is absolute neutrophil count, nothing but the percentage of neutrophils among the total WBC count. So plus any percentage of band cells also we will add to that. So that is percentage of neutrophils plus percentage of bands into the total WBC count by 100. It is nothing but simply if the neutrophil count is 80%, neutrophil percentage is 80%, which means of the total WBCs, 80% are absolute neutrophils. You can calculate it simply like that also. Some of the CBCs will give the number as well. So there is another guideline. Obviously, there is a American guideline and European guideline. So European Society of Medical Oncology has defined febrile neutropenia as an oral temperature more than 38.3 degrees Celsius or 2 consecutive readings more than 38 for 2 hours, and an absolute neutrophil count of less than 500. But we will stick to the ASCO guidelines. Okay. So whenever the patient comes with fever to the triage within 6 weeks of receiving chemotherapy, we will be suspecting febrile neutropenia. So we will assume some bacterial infection. We will document the fever, draw all the samples, and then within 15 minutes of triage, what we have to do is we have to conduct a systematic assessment and maximize the chances of establishing clinical and microbiological diagnosis. Okay, so that should happen within 15 minutes. Within 15 minutes, all your systematic examination and laboratory things all should be taken. And within 1 hour of triage, the first empirical antibiotic should be administered. And identification of candidates for OPD treatment and IP treatment. We will come to that in detail. This I have a different slides in the upcoming slides. How to who are the high risk patients, who are the low risk patients, who can be candidates for IP management, who should be treated on an OPD basis. We will discuss in detail. Okay. So history taking as usual. We should take the history and try to identify the source of infection or the focus of infection. It could be GI, it could be CNS, it could be urinary, it could be skin and mucous membrane, more in common in this malignancy patients receiving chemotherapy. It could be LRTI or respiratory complaints or any indwelling any catheters. And also we should examine the perineal region and ask about any pain with defecation. Usually, though there is no too much evidence for suggesting this, but expert opinion is avoid DRE to avoid compromise of the rectal flora barrier. To avoid that, we usually do not perform DRE, and may say otherwise also routinely we don't perform DRE on any patient unless otherwise indicated. And investigations, routine all the investigations which we send, complete blood count, which would include a leukocyte differential count, which because we need to calculate the absolute neutrophil count, hemoglobin, platelet, serum electrolytes, LFT, RFT, and blood gas analysis. These are the routine things which we do. And 2 sets of blood cultures are very important. If there is a central catheter, one should be from the central venous catheter and one should be from a peripheral site. If there is no central venous catheter, 2 sets of blood cultures should be taken from different separate venipuncture sites. And then other cultures like urine, lower respiratory tract, any cultures like bronchoalveolar lavage, etc. CSF culture, stool culture, wound or pus culture, etc. as indicated. Not routinely done in all patients, depending on the clinical features and symptoms. Chest imaging, if the patients have signs or symptoms of lower respiratory tract infection. And patients with influenza-like illness, we should consider nasopharyngeal swab for detection of any influenza virus. And in some settings, the patient has, especially if it is a stem cell transplant patient and having some respiratory symptoms, we should also consider respiratory viral panels, including the metapneumovirus and the pan-respiratory panel. That is not in all cases, especially in stem cell transplant recipients, it is important. And next, we all know the mask risk index. Okay, so that is the Multinational Association for Society of, what was it? Full form I forgot. Supportive care in cancer. So that is a risk index, nothing but to see the prognosis outcome or who are the patients who are at high risk of developing complications. So we know lower the risk, lower the score, higher the risk. And there is just opposite. So you don't need to by heart this. It is available in that MedCalc. You can calculate it and see. If the score is more than or equal to 21, it is low score. If it is less than 21, patients are at a high risk of developing developing complications and poor prognosis. Okay, that is one scoring system, and another is the clinical index of stable febrile neutropenia, CISNE score. This is also another scoring system. So here we can see again the performance score. This Eastern Cooperative Oncology Group performance score is nothing but you can Google and see. It is a performance scale like the modified ranking scale, like pre-disease, how was the patient performing. Based on that, there is a scaling system. And then stress-induced hyperglycemia, COPD, chronic cardiovascular disease, mucositis, monocytis count, etc. based on this. So this also tells about the risk of complications in 7 days. So these are the 2 most important scoring systems to predict who are the patients at high risk. So here we can say if the mask score is less than 21, they are a high risk group. So now coming to who are the other than this mask score, whom all we consider as high risk patient. This is very important because based on the high risk and low risk category, we will decide to say whether to start them on IV antibiotics or whether to send them on oral antibiotics. So profound neutropenia, that is ANC less than 100 and anticipated to extend more than 7 days. Presence of any of the comorbid conditions like hemodynamic instability, oral or gastrointestinal mucositis that will interfere with swallowing or cause severe diarrhea. GI symptoms like nausea, abdominal pain, vomiting, diarrhea. Neurological or mental status changes. Intravascular catheter infection. Any new pulmonary infiltrate hypoxia or underlying chronic lung disease. Evidence of any hepatic insufficiency or any renal insufficiency and masks or less than 21. All these are your high-risk patients who cannot be sent home on an oral antibiotic therapy. All these patients require IV antibiotics and inpatient treatment. So who are the low risk patients? Neutropenia expected to resolve within 7 days. No active medical comorbidity. Patient is stable and the hepatorenal function is within normal limit. They are the low risk patient. So coming to the treatment part, first dose of empirical antibiotic should be administered within 1 hour. As we have already mentioned, within 15 minutes, all your examination investigation should go. And within 1 hour, like usual sepsis protocol, within 1 hour, the first dose of empirical antibiotic should be administered. So we have seen this. I would ask everyone to take a screenshot of this high risk patients and low risk patients. Okay. So treatment for the low risk patient. You can see some of or majority of the patients will be on fluoroquinolone prophylaxis already. So if they are not receiving fluoroquinolone prophylaxis, all these low risk category patients, you can discharge them on ciprofloxacin 500 mg BD or levofloxacin 750 mg OD or plus amoxicillin clavulanate or clindamycin. So one fluoroquinolone plus amoxicillin clavulanate or clindamycin. These are the patients who are not on fluoroquinolone prophylaxis. But before discharge, they should be observed for like 4 to 6 hours. But if the patient is receiving fluoroquinolone prophylaxis already, they should not receive further FQ-based oral therapy. They should be admitted and started on IV antibiotics. So basically, you have only very narrow range of patients who can be sent home for oral therapy. That is our low-risk patients. That is neutropenia expected to resolve in 7 days. No active comorbidity, stable patients, adequate hepatorenal dysfunction, and who are not receiving already fluoroquinolone prophylaxis. Then we will discharge on Ciplox or Levoflox plus amoxiclav or clindamycin. Okay. And if they are receiving, they should be already on FQ prophylaxis. They should be admitted and IV antibiotic should be given. So coming to the high risk patient, we will usually start with monotherapy. That is, we can consider piperacillin tazobactam, cefepime, ceftazidime, imipenem or cilastatin or meropenem, and the doses are also given here. So that is monotherapy. So when will you consider dual therapy? That is, when will you add vancomycin or other agents which are additional gram-positive coverage? When will you add? That is, one is suspected catheter-related infection. If there is a skin and soft tissue infection, if there is pneumonia, if there is hemodynamic instability, and if antimicrobial resistance is suspected or already proven. In these cases, we have to add vancomycin or any other gram-positive coverage. And if there are abdominal symptoms present, we should add metronidazole 1 gram followed by 500 mg every 6th hour. That is in case of abdominal symptoms. So this is an indication for additional IV antibiotics against gram positive, which we have already mentioned. Hemodynamic instability, pneumonia, blood culture, positive blood culture, skin, soft tissue infection, catheter-related infection, severe mucositis, we have already mentioned. Same thing. So this is when you consider dual therapy. Now coming to some modifications of antibiotic therapy. So if you are suspecting MRSA, early addition of vancomycin, linezolid, etc. should be added. Or if there is no pneumonia, daptomycin should be added. VRE is vancomycin resistant enterococci, consider early addition of linezolid or daptomycin. ESBL is extended spectrum beta-lactamase. There we have to consider early use of carbapenem. And KPC is Klebsiella pneumonia carbapenemase. consider early use of polymyxin, colistin, tigecycline. All these higher antibiotics we should consider when we are suspecting or any of these MRS, VR, etc. are proven. So next question is, how long should the empirical antibiotic therapy should be given? So in patients with clinically or microbiologically proven infection, the duration of therapy is indicated by the organism and the site. But ideally, we consider, or appropriate antibiotics, we consider at least during the till the neutropenia is resolved. That is, ANC is more than or equal to 500 or longer if clinically necessary. So that is the basic criteria which we keep. If that is when the ANC pick up more than 500. In patients with unexplained fever, it is recommended that the initial regimen can be continued till there are clear signs of marrow recovery. And again, the endpoint is considered as ANC more than 500. But if all the symptoms are resolved, symptoms and signs have resolved, patient is febrile, but neutropenia is just persisting. In that case, you can stop the antibiotics, but resume the oral fluoroquinolone prophylaxis till marrow recovery. This is when all other symptoms and signs have resumed, but only the thing is the patient will need time for the marrow recovery. In that case, you can stop these antibiotics and then continue with the fluoroquinolone prophylaxis. Okay. So next is when to initiate antifungal therapy. So there are two things. Basically, now it is empirical antifungal therapy and preemptive antifungal therapy that is coming now more popular. So empirical antifungal, when will we consider? That is persistent or recurrent fever after 4 to 7 days of antibiotics. And the overall duration of neutropenia is expected to be more than 7 days. So in patients with the stem cell transplantation and chemo in AML patient, we consider fluconazole. For AML, hematopoietic and MDS patients, for aspergillosis cover, we consider voriconazole or posaconazole. Okay. So this is empirical, but nowadays we are shifting more towards a preemptive antifungal management. Preemptive means it is nothing but we will initiate antifungal therapy only if there is a definitive diagnosis of invasive fungal infection. This is to reduce the unnecessary use of antifungals. So when will we initiate in preemptive antifungal? That is, those who remain febrile after 4 to 7, but if the patients are clinically stable, they do not have any clinical or chest or sinus infections or sinus infection of any fungal etiology, have negative serology assay for any invasive fungal infection. In all such cases, we can withhold antifungal agents. Okay. Just it is the fever which is persisting, but all other things, including the microbiology, is negative for the fungal infections. We can consider to withhold invasive fungal agents. Okay. If any of the above is present, then we have to consider antifungal therapy rather than, so this is a more sustainable approach rather than blindly adding antifungal for every patient who has a fever persisting for more than 4 days. Okay, so next is when to consider antiviral therapy. HSV seropositive patients who undergo allogenic stem cell transplant or leukemia induction therapy, they should receive prophylaxis, acyclovir prophylaxis. And antiviral treatment for HSV or varicella is indicated only if there is a clinical or laboratory evidence of active viral. So again, antiviral is also not routinely indicated unless there is a clinical or laboratory evidence. And respiratory viral testing, chest radiography with upper respiratory symptoms should be considered. Again, more commonly we can test the influenza virus, and in stem cell transplant patients, as I have already mentioned, the respiratory panel should be tested. And all these cancer patients should receive yearly influenza vaccination. And influenza virus infection, if it is confirmed, then it should be treated with neuraminidase inhibitors. And in setting of an outbreak, what we will do is, we will, like any influenza-like illness, we will, as any other normal patient, we will give oseltamivir empirically. So routine treatment of RSV is not indicated. So basically what we have mentioned here is antiviral therapy. Seropositive patients, stem cell transplant patients will have antiviral prophylaxis. They might be already on. Unless there is a clinical or laboratory evidence, antiviral treatment is not indicated. Respiratory, if there is an influenza-like picture, respiratory symptoms, consider chest radiography and respiratory virus testing. All malignancy patients should have a yearly vaccination for influenza, and influenza virus infection is confirmed, then they should be treated with neuraminidase inhibitors. And if it is a seasonal outbreak time and presenting with influenza-like illness, we should give them empirically oseltamivir or neuraminidase inhibitors. Okay, so next is use of the colony stimulating factor in high risk. So this I have taken from this European Organization cancer guideline. So we have to assess the risk of FN associated with the planned chemotherapy regimen. So if the FN risk is more than or equal to 20%, prophylactically GCSF is recommended. If the FN risk is 10 to 20%, assess the factors that increase the risk of FN, like age more than 65, other comorbidities, etc. And including that, if the overall FN risk is more than or equal to 20, we again give GCSF. If the risk is less than 20, it is not, prophylaxis is not indicated. And if the FN risk is less than or equal to 10%, GCSF prophylaxis is not indicated. And after each cycle of chemo, this should be reassessed. So these 3 slides I have taken again from the ASCO guidelines, IDSA guidelines. Again, this is the overall summary of what we have described. Fever and neutropenia, how we calculate who are the low risk patient, who are the high risk patient, how to start oral antibiotics, IV antibiotics, etc. And then day 2 to 4, after 2 to 4, if they are responding, not responding, what to do. Again, all the same things which I have already mentioned. I will share the articles I will share will have these algorithms. Okay. So one another thing is what environmental precaution should be taken while managing febrile neutropenia patient. Again, something which we do not pay much attention in the emergency department, but which should be taken care of, like hand hygiene, isolation and barrier precaution, food neutropenic diet, room ventilation, patient skin and oral care, plants and animals, like they should be kept away from all these pets, pollen, etc., which are allergy. Healthcare workers and visitors, infection control surveillance, all these things should be also taken care of for the successful management of febrile neutropenia, among which not all the things can be done in an emergency department, but some of these things can definitely be incorporated in our management. So that was all about febrile neutropenia, brief about febrile neutropenia. Now coming to the second topic, that is hypercalcemia of malignancy. Again, yet another important topic. So hypercalcemia is seen in 5 to 30% of patients with advanced cancer. Breast cancer, lung cancer, multiple myeloma are the malignancies most commonly associated with hypercalcemia. So we all know there are multiple mechanisms for this hypercalcemia of malignancy. One is the synthesis of parathyroid analog PTR, parathyroid analog, hormone analog, that is PTH related protein. Okay, that is the most common mechanism. Second mechanism is overproduction of calcitriol or vitamin D analogs. Then bone osteolysis because of the direct spread of tumor, and less commonly ectopic production of parathormone. So we can see most common is this parathormone related peptide, that is seen in 80% cases, mostly in breast cancer, non-Hodgkin's lymphoma and lung cancer. And parathormone, as I have mentioned, less commonly ectopic production of parathormone. This is seen in rarely. This is very, very rarely. Calcitriol is seen in mostly in lymphoma, but again less than 1%. And the second most common mechanism is osteolysis from direct skeletal spread of the malignancy. That is again seen in 20%. So most common mechanisms are this parathormone related peptide and osteolysis, which is given in this image, which is again I have taken from NEJM. So this parathormone related peptide mechanism is also known as the humoral hypercalcemia. And that is 80% contributing factor. 20% cases, it is the local osteolytic hypercalcemia. Okay. So clinical features, we know there will be generalized weakness, lethargy, confusion, renal injury, abdominal pain, nausea, vomiting, diffuse body pain, constipation, polyuria, polydipsia, some arrhythmias, etc. So investigations, blood gas analysis, ionized calcium level and serum calcium level, we have to see for the corrected calcium. Corrected calcium is 0.8 into normal albumin minus patient albumin plus serum calcium. Then ECG for any hypercalcemia changes and additional metabolic panel to see for any other electrolyte abnormalities, renal function tests. These are the important investigations. ECG, we know what are the important changes which can be seen, that is shortening of the QT interval, Osborne J waves, and ventricular arrhythmias. So here we can see the arrow point towards that is the Osborne wave, and QT, you can see the QT is shortened here. Okay, so that are the important ECG findings which you can see in hypercalcemia. So treatment is not required if the patient is asymptomatic and well hydrated, and if the total serum calcium is less than 14 milligram per deciliter. But if it is more than 14 milligram, even if the patient is asymptomatic, you have to treat the hypercalcemia. So if it is asymptomatic and well hydrated and serum calcium is less than 14, treatment is not required. So how do we treat? So I have classified it as drug, the mechanism, dose, onset of action, and the additional things. So first, most important thing in the management of hypercalcemia is nothing but IV hydration. So we have to give normal saline, which will restore the intravascular volume and also increase the urinary calcium excretion. If it is hypovolemia, 1 to 2 liter bolus over 1 hour, and then you can continue at 250 to 500 ml per hour, followed by 100 to 150 ml per hour. So it will take some hours. So here you have to modify it according to the patient's cardiovascular status, and also CKD patients, you have to manage the fluid accordingly. So most important thing is maintaining IV hydration. Second is furosemide. Again, it increases the urinary calcium excretion. Okay, so dose is 20 to 40 milligram IV. Again, it will take some hours. Do not routinely needed, but if the patient is having heart failure or renal failure, we can use it also to prevent fluid overload, because we are loading the patient with a lot of IV fluids. Next is zoledronic acid. So it inhibits the bone reabsorption via interference with osteoclastic function. The dose is 4 mg IV over 15 minutes. Onset is 24 to 72. Ideally, this is the drug of choice in malignancy, but we should use with caution in renal failure. And calcitonin. So we usually give calcitonin, and zoledronic acid is not routinely used. Calcitonin inhibit bone resorption, again by interfering with osteoclast function, and also promote urinary calcium excretion. The dose is 4 to 8 in international unit per kg subcutaneous every 12th hourly. Onset is pretty faster, 4 to 6 hours. But there is a risk of tachyphylaxis. That is a problem with calcitonin. Next is glucocorticoids. Again, it will decrease the intestinal absorption of calcium and decrease calcitriol production. So we can give prednisone 60 mg OD or hydrocodone 100 mg 6th hourly as IV. So mainly it is used in hypercalcemia due to lymphomas and multiple myeloma. Denosumab, it inhibits the bone resorption via inhibition of Rankel receptors. The dose is 120 mg subcutaneous weekly for 4 weeks, and then every 4 weekly. But not much use in emergency because the onset of action is 4 to 10 days. It is used if it is refractory to bisphosphonate, like your zoledronic acid. If it is refractory, in such cases, you can consider denosumab. So, hypercalcemia, we have the treatment, how we treat and based on the etiology. Most important thing is increase the calcium excretion, that is increase calciuresis, that is IV fluids. Then reduce the bone resorption, that is by your IV bisphosphonates, calcitonin and denosumab. Reduce intestinal absorption by glucocorticoid, and reduce parathormone again by use of calcitonin. So this is how you manage hypercalcemia based on the etiology. So yeah, that is it. Brief about management of hypercalcemia in malignancy. So we have completed 2 topics of febrile neutropenia and hypercalcemia in malignancy. So any major doubts you can ask here. Baki